Welcome, eGPlearner, to this episode with myself and Andy talking about the DDRB report and how this can impact general practice moving forward as they've made their recommendation of what the pay uplift should look like, as well as various other stories, including Capita, trainee placements, and various other news stories that's going to impact general practice as we continue to tech enhance your primary care and learning. Hello, eGPlearner. Welcome to this episode. We're talking about DDRB, pay, and various other financial stuff, as well as a few extra stories as well for you in general practice. How are we doing there, Andy?
Yep, I'm pretty good. Been off the first few days of this week following the bank holiday, so feeling a little bit more rested than usual. How about yourself? Doing okay?
Yeah, similar. A couple of days off, seeing how that goes in practice as we head back into it tomorrow. And as ever, loads of news stories coming through, with the big one being about the DDRB report that came out, which was alluded to in the GP contract stuff that you and I talked about a few months back, that, this is something that the government said they were going to respond to. We still haven't had that official response yet, I don't believe. But it'll be interesting to see what comes through, because the BMA definitely have responded, and it's interesting stuff, that's for sure.
So that's the main story today. I guess the other stories which we will be covering are we have a story about ICB imposing GP call response targets like call centres on their practices as part of an enhanced service contract. Capita are going to run GP support services, including pensions, for another 3 years. And a politician who I found a bit of a blast from the past has written a letter to Parliament about that. Obviously, England's GPs to receive 4% pay uplift. That's our main story, looking at the DDRB's report. And we'll have a look at what's actually kind of in that report and kind of have a little bit of a look behind the headlines there, which will be interesting, I think. GPs could be liable for third-party errors in patient records, warns BMA, and then GPs criticise juniors for protectionist policy against international graduates, which is an interesting and potentially controversial story. So that's what people can look forward to coming up.
Okay, and let's get started, shall we, with the first part of that, which is the DDRB report. So this is the document that basically tells a lot of organizations what they should want to, or may want to consider in terms of pay uplifts, and then depending on your contractual status, may be compulsory, may not be, etc. But this is the thing that many people look at in terms of pay uplifts across the board when it comes to doctors, dentists, plus others, shall we say. But yeah, shall we get started, Andy?
Yeah, let's go. So as ever, we start with a story in Pulse, friend of the podcast, and they've obviously picked up on this report that was published. I think last week, 22nd of May is the time here. Does the report have the date on it? No, it just says the 53rd report, but let's go back to the story. So I guess the headline here is a 4% increase to salary scales for all doctors and dentists. So across the board, including consultants and SAS grades, junior grades, 4% for everybody. And obviously, I guess the BMA has different components that respond to different parts of this, and we're mainly going to be talking about the GP response here within this podcast. So that's the headline. 4%. Yeah. There are a few other headlines which relate to general practice. So uplifting the pay range for salary GPs by 4%. Uplifting for GP educators. So I guess that's the component that GP educators get paid, by 4%. There's what's the term used? Is it GP contractors? But essentially GP partners for the first time, I think, at least since that 5-year deal that we had in 2019, having a pay recommendation with an uplift of 4%. Uplifting the salaries of consultants by 4%. Uplifting general dental practitioners by 4%. And uplifting the pay scales for specialist and associate specialist doctors on all contracts by 4%. So 4% across the board is the headline. Initial thoughts, Candy?
So like you say, it's pretty much across the board, 4% increase for all staff. Reminder, this doesn't include nurses, agenda for change, all that. Although that tends to be where a lot of people look for the number of where to increase additional contracts like those, and many people often will then use the same number to apply to other staff in terms of healthcare and that kind of thing. But that's not a mandated aspect of it. The other part that it mentions also is this uplifting of flexible pay premiere by 4% on consolidated. So this is for those specialities that are more difficult to recruit into. And there's also a suggestion that they will reduce the amount for general practice, because general practice is more oversubscribed in comparison to some of the other specialities at this point in time, even though there aren't enough places because of the workforce applications and stuff that are currently happening. But it basically talks about this number of 4% repeatedly throughout, which is really interesting because the BMA have come back and said it's not enough.
No, or yes, they've said it's not enough, and there are all sorts of challenges affecting general practice. So he said, Katie Bramble-Stamer has said, this is not going to be enough to realise the government's ambitions to fix the front door of the NHS or expand GP teams and bring back the family doctor. And that's really, really sensible, because increasing the GMS workforce component that is calculated to the proportion of the GMS payment for workforce, the proportion of that which is for GP salaries, increasing that by 4% is not transformational in terms of allowing more GPs to be recruited. For example, it might be nearly sufficient to retain those GPs that already work there and pay them an uplift in terms of their salary, but it's not transformational by any means. So I think she's absolutely correct there.
Well, I think it's also getting deeper than that, Andy. So it's important to remember that the current GP contract, in terms of the amount offered as of April, only actually allowed an increase of 2.8% within the contracting mechanism for staff increases and stuff. So part of that impact then says if DDRB are coming out of 4%, there's a 1.2% shortfall in terms of staff pay increases that exists. And that also doesn't include, pay increases, as we mentioned, for contracted general medical practitioners, so basically your partners. So where does that funding come from? So the key point about this, even though, from the GPC's perspective, that 4% isn't enough, the existing 1.2% recommended increase is not currently funded in the GP contract. So there isn't enough money provided to give this as it stands, unless the government comes back with a response of an increased amount of funding for general practice.
Absolutely. It's a similar situation to previous years, isn't it? Because we have this strange arrangement where the increase in terms of the contract is announced a few months before the actual pay recommendation for GPs, which doesn't really make sense. And then what normally happens is later in the year, and it often comes a lot later than you would think, the government decide quite how they're going to respond to this recommendation by the kind of arm's length independent body, which is the Doctors and Dentists Review Board. And often we get a response where they work out about how much money they think the average practice would need to honour this, and then they send that through in the GMS, going forwards for the rest of the year, and are backdated around to cover the amounts from April. And GP practices often have to make a calculation and pass on what they get to their staff, and sometimes what they get is not enough to honour the recommendation. So it's always very messy every
Absolutely.
year, and of course we're never quite sure as a practice whether that money is really going to land and come until it comes. So we have to wait for it to land to provide those pay increases, and people are often waiting until halfway through the year to get them,
or longer. Because reality is that they may come increase is in September, October, but then by the time they come through from the cash flow perspective, you're talking October, November, and then by the time the practice have then done the calculation, you're talking November, December. You're right; it's much later than people think it tends to be.
Yeah, so it's always complicated. So I think Wes Streeting has said a few things about this. I think he said, over the past few months, we have identified how extra funds will be freed up by cutting duplication between the Department of NHS England and cutting NHS England headcount, slashing budgets for corporate services like NHS communications teams, and bringing down ICB costs by 50%. As a result of the savings found, none of the pay increases will be paid for by cutting frontline services. So they're sort of making a case for why this won't require fundings to be taken from frontline services. I'm not quite sure how Department of Health will make it whole, but they're indicating their intention to by making the justification for how they have already made the savings to pay for it.
So
yeah,
I guess I'd be keen to know from our eGPlearners what they think about the DDRB increases. So I'll put that in the chat if you're on Facebook or YouTube. If you're on another platform, say X or the other ones where people streaming in from, then absolutely let us know as well in terms of the comments what you think. Is 4% the right number? Should it be more? Should it be less? If it not, then how do you think that's going to work if it wasn't to be funded in the GP contract moving forward as well? Because I think that's where some of those discussions, particularly for staff, are going to be going in terms of, well, DDRB says this, you should be giving me a 4% pay rise. Many practices are probably sitting there thinking, where is this money coming from that we can provide to our staff?
So Gandhi, might be worth just having a look at the report itself. Again, it's one of those reports that I'd really encourage people to have a look at, because it's interesting. So we did a video last year, which is just popping on the screen, where we had a real in-depth look. It's only about 20 minutes long, but it's quite an interesting video. I watched a bit of this, and one of the first things I say was, this is a really interesting report, despite being only 187 pages long. So I think it's a similar. Yeah, I think it's a similar length.
Actually, I think this one's 287. They've chucked in a few extra pages, that's for sure.
Well, maybe that's because GP partners are included. So people can go and have a look at that if they want to kind of have a look at the structure of the report. And we won't go into detail on it, obviously, because of the length. But it's worth just having a look at it, actually. You know, if you've never had a look what's in it.
Apologies, Andy. It's 237, not 87 pages. So they've added an extra 50 pages for the GP partners.
There we go. So but it is worth having a look at, because it's really, really well researched and constructed. They do a really, really good job, and they're a sort of arm's length independent body. So they're supposedly free from, government pressure, coercion. They provide an independent view, and they really outline their remit that they've been given and the methodology that they apply to reach the conclusions that they reach. So let's just have a few little bits. So the wider context section is really interesting. And they look at all sorts of things. So they look at rates of inflation. Let's have a look. They look at the consultation rates. They look at NHS product. So A&E attendance is here. They look at NHS productivity, number of patients waiting for treatment. Or there's the public health services productivity. Actually, it's interesting, where people say, "Oh, we haven't returned to the productivity levels pre-pandemic." This kind of demonstrates those sorts of.
Can you zoom in a little, Andy?
Zoom in. Let's. Public service healthcare productivity 2010 to 2023. So. And it's looking at the percentage change based on a baseline at 2010. So I guess pre-pandemic, you might say, "Oh, we'd achieved, 18% productivity increase based on 2010, and then it went down during COVID, and we've not actually regained that 18% increase based on the baseline in 2010 yet at this point. Although it looks like data is still in an upward trajectory. So where people say, "Oh, productivity hasn't returned to pre-pandemic levels," this is the sort of data that they're talking about, and the sort of data that's in the DDRB report. So just really, really interesting to look at what they include. They look at NHS funding, staff spend in the NHS, all sorts of things. Another interesting area. So, as we always say, when you're picking up these reports, read the foreword and read the contents page to have a look at, and then jump to the bits that you're interested in. So, we're obviously interested in the general practice area, and let's look at the pay comparisons area, because it's interesting that they compare, for example, GP salaries on an absolute and full-time equivalent basis with other, what I guess they're considering, equivalent professional jobs. So they're looking at analytics and data science people, people who work in legal, finance and accounting, pharmaceutical industry, people with similar levels of qualification. And I guess there's we need to attract people who might otherwise be attracted to those professions with reasonable levels of pay. So so these are the sorts of things that inform the pay award recommendations. So and this is really interesting because I think this first graph looks at full-time equivalent pay. I think the second graph
again, can you zoom in a little bit, Andy?
Yeah, so just looking for my plus arrow. Yeah, so this looks at full-time equivalent pay. So you see a full-time equivalent contractor GP, so that's a GP partner, full-time equivalent. This is the important consideration here. This is the sort of pay range that they might which is similar to someone working in the legal profession, for example. However, if you look at absolute pay or total earnings, which actually takes into account that a lot of people aren't capable of working 10 sessions a week as a GP partner, particularly doing clinical work, because it's just physically impossible to do that, because that represents an enormous number of hours per week. So actually the total earnings, and of course, I guess if we're being fair, maybe more GPs, choose to work part-time to look after children and have other, other activities compared to these other jobs as well, although quite that they would, I think. I'm not sure that that's the case. But anyway, total earnings actually less than these other professions. For example, legal, accounting, pharmaceutical industry, data analytics. So just interesting that they take all of these things into consideration. And the report is full of these considerations and comparisons, and they look at what the workforce is, what the workforce might need to be in the future, and how pay can influence this as a tool to achieving the workforce that's required to meet the NHS's needs going forwards. So it's really, really interesting. Probably making people dizzy scrolling around, but I just want to get to the actual recommendations. So if you want to jump to the recommendations, it's in chapter 1. And then
of which in total, I believe there's 7 different recommendations that they make based around the 4% uplift being the key one, which is that number 1. And then various other ones. There's 2 focusing on dentists in particular that come through. And there's pay premier one that we talked about as well.
Yeah, they break them out into these green boxes, which is really, really helpful to pick them out and look at them. So there's the 4% increase across the board for all of those categories of job. And then they provide some context and justification around that. Recommendation 2, 4% increase plus a consolidated uplift of £750 to the pay points for resident doctors and dentists in England. So that's a £750 increase on top of the 4%. Recommendation 3, we recommend that governments consider a separate pay framework for locally employed doctors. What's your understanding of that, Gandhi? I'm not sure I fully understand.
I'm wondering if that's things like SAS and that kind of stuff, so the locally employed ones that would come through in that basis.
I don't know, but I guess if you feel that applies to you, then certainly read in more detail the report. Recommendation 4, we recommend the government reviews flexible pay premia in England to assess their value for money and effectiveness. So I think you were saying that's
around those more harder to recruit to specialities where they know that they've got loads of people, for example, coming through core training, but then there are some specialities where it's harder to recruit to, and as a result of that, there's pay differentials. They did mention about in particular areas of general practice where it's harder to recruit to, that some of those schemes are due to finish in 2025, and areas may want to reconsider different opportunities in terms of what that might look like on that basis.
Good. Let's get through the rest of the recommendations. So recommendation 5, we recommend an increase in the value of National Clinical Impact Awards in England and Wales. And it goes through the various levels. What are these Clinical Impact Awards? This is to do with consultants.
It is. Doesn't apply to GPs, unfortunately.
Yeah. Yep. 6, we recommend that the 4 governments work with GPs and dentist representatives to develop an index of general practice costs and an index of dental costs. These indices should then be used to determine the expenses element of the GP and dental contract uplifts in each nation. So Okay, fair enough.
Yeah.
And recommendation 7, we recommend that each government should undertake a review of pay and progression for salaried dentists working in community and public dental services to assess whether the reward structure is appropriate to support recruitment, retention, and service delivery. So I guess there's concern about provision of NHS dentistry, and they're making recommendations to try and support and improve that. So I guess we'll wrap up having a look inside the report now, but do pick it up, at least have a look at the contents, and jump around, and hopefully that's reduced people's barrier of entry to having a look at that document.
We've definitely got some comments coming through, and I'm going to see if this works now. So hopefully it does. No, it doesn't. Okay, let's try the other way and see if it works that way. Oh no, it's not working. Okay, so there's meant to be a way that we would see the comments in a slightly different way, where we see everyone's comments and stuff, but instead let's just bring on what we've got. So Amy Lukewood, we absolutely need more money, but crucially sessional GPs need a mechanism to ensure they get the money. I agree in that, in the sense of in terms of understanding how the money can be transferred across those staff where it's applicable to. I'm still going to bring up that point that the current contract mechanisms doesn't allow for a 4% uplift across the board. So practices that are able to offer that are probably either in a better financial situation or in a situation where they know that their staff have that impact value, but also raises the question of sustainability. If those funds are not carried forward through by the government, so this may be something that doesn't come through till later on in the year when the government does actually respond in terms of financial aspects. I think Jay...
Again, I was just coming to Amy's point. So I get, it's an interesting point that Amy makes, isn't it? And I guess she's referring to locum GPs there, because their pay rates are largely set by market forces to a certain extent, in terms of supply and demand of locum GPs, and supply has been increased relative to demand in the last year or two or three, relative to more recent historical levels, where a few years ago it was very difficult to get locum and sessional GPs, which led to quite high rates. Sometimes you would hear partners grumble that the GP locums were paid more than they were for a while, but that's certainly a reversing thing. So that's interesting. Yeah, and I don't know if there is a mechanism. Yeah, I'm not quite sure what the mechanism is. I
think she's clarifying about salary GPs, and this is the new comments mechanism that you can see coming through, so it seems to now be working. But then we also have the comment from Jayesh Puri talking about happy to pass on the money to staff as long as we see it coming in. Previous years, it's been difficult to understand how the money coming in was supposed to cover the rises. I know that was definitely the case in the last financial year. There was a suggestion of a 6% pay uplift for staff, and many practices realised that actually that was just not coming through in terms of the funding mechanisms and stuff that people were saying.
Yes, and I think many practices will say, well, we will pass the money on when it comes through, to the extent that it comes through, and practices are often quite transparent about that, where I've seen it done quite well in terms of this is the money, these are the calculations, sort of thing, without giving away people's individual rates of pay, of course, and so forth. But there is a way to do it that's transparent. Well, there we go. So I guess that's the main story.
It is.
I almost feel like, Gandhi, that I need to go and sit on the sofa and have a little rest for a second, if you know what that means.
Yep, absolutely. So,
Gandhi, while we're taking a break on the sofa, I've got a question for you.
Okay.
Our practice has been looking for ways to make things run more smoothly, better, more efficiently, improve patient care, and ideally to make a little bit of extra income as well. And I was wondering if you found anything that actually helps.
Yeah, so we've been in similar situations. Managing long-term conditions take up loads of time. So, there are various tools out there, and the one I would definitely suggest to have a look at is Primary Care IT. It's made such a difference.
And that's interesting. How does it fit into and work with your existing systems?
Well, that's the cool thing. It integrates with all the clinical systems that we've got currently, so TPP, EMIS, and Medicus as well, if you've got access to that. And they work really well, rather than adding that extra step, because you can launch them through the systems.
And I've heard about the QRIS3 calculator. Do you use that?
Yeah, so I know it's already built into EMIS, and they're looking at TPP integration soon. And then the benefit of having that straight away is the fact that it's integrated straight away. You can get the risk scores without having to switch back and forth between all the websites and the other kind of tools and stuff that takes so much longer.
Oh gosh, that is a headache. So I'd love to avoid that. Sounds really useful. But what about support? New tools can sometimes be more hassle than they're worth.
Definitely, but I think their support is really solid. They have loads of onboarding support that you can have, webinars, resources that you can access as well through their website as well, and regular contacts that you can use.
That sounds really good. Sounds like something that we'd be interested in as a practice. How would we get started?
Well, I'd definitely check out their website. It's primarycareit.co.uk. That's basically where you get all the information you need, their contact details, as well as demonstrations of what they can do for you in practice, and also what's coming soon as well.
Oh, fantastic. We'll get started.
So definitely check out Primary Care IT if you need some additional support and things that may be relevant for some of the stuff we're talking about. And interestingly, I'm going to jump in with a story that me and Andy weren't going to cover, but just very briefly going to talk about. I mentioned on there about Medicus, which some people may have heard of and things, which is this new EPR, electronic healthcare system. And the reason why I mention it is there is a practice that has the first to transfer from EMIS to Medicus, gone live with it last week. Friends of the channel, the WilmslowGP team, so Dr. Fari and Dr. Amar Ahmed, they do some amazing stuff, and they have just gone live with the Medicus online system. If you want to check out their journey, then definitely have a look at their content that they're providing. It's the WilmslowGP YouTube channel, and they've got various blogs and diaries and stuff they're putting through in terms of what that looks like moving forward as well.
It's going to be really interesting to see. So so they're vlogging their experience of changing their EMR.
Yeah.
Okay, that's going to be interesting. Maybe we should keep in touch with that and see how that develops. Okay, good.
Cool. So next up, we're going to talk about Capita being back, I believe, wasn't it, Andy?
I think so. Well, we've got a few things. Capita,
yeah.
or there's the ICB performance management.
Let's go with Capita first, shall we?
Let's get Capita. Let's get that out of the way, because that may not be good news for people.
So this news story comes from the basis that effectively two aspects about Capita. So the first one being that the Capita contract to run the PCSE service has been extended for another 3 years in total, with 18 months continuation and an 18 months transfer period, totaling of £82.5 million for the first 18 months. Effectively, Capita is here to stay. This was due to finish this September, the contract, and provided to another provider. But I suspect, given the change to NHS England, various other aspects, this is a contract they've not been able to renegotiate with other providers. And as a result of that, has now gone back to Capita.
Yes, so it's been extended for another 3 years. And I believe it's worth £82.5 million going forwards for the next 3 years. There's a range of back office services that they're supporting PCSE with, but in particular the GP pension service, which I'm sure we've either had direct contact with or seen colleagues nearing retirement age,
frustrations, pains, problems,
wrestle with, to try and get an accurate pension appraisal, and often people do not have good things to say about Capita's performance there. It's interesting that, I guess, it sounds like maybe it's gone to Capita because they were struggling with other providers, and I've often wondered whether the contracts resource these things adequately. Often we find that the people who step in and do the dirty work of providing these services, perhaps for contract values that don't allow them to meet people's expectations, and maybe the contract just isn't sufficient to do a good job. I don't know. This is something I've often wondered, although the headline figures feel like quite big sums. So a lot of people will not be happy about that. One of them is the BMA Pensions Committee Deputy Chair, Dr. Krishan Agarwal, who pointed to a recent Freedom of Information response that found over 18,000 GPs across England do not currently have an up-to-date pension record. I was one of them, but I managed to get. I did a lot of emailing and calling PCSE.
I'm still having to do it, so my current years are not there on their stuff. They seem to have forgotten I existed for a couple of years.
Yeah, it took me a few years to get an up-to-date pension appraisal, but I just thought I ought to, because I couldn't see anything on the website, and I started to think, does my pension actually exist? They've been taking the money, so I felt I needed to really pursue it, and it does exist, but I wouldn't know that unless I chased it. So another person who is not happy about this is none other than Suella Braverman. Do you remember Suella, Candy, and her previous role in
Former
the government?
Home Secretary, wasn't it?
She was the Home Secretary for
Yeah.
a while. I think under Rishi Sunak. I think
Yep.
he was
And I believe she put in a candidacy for party chair as well, but it lost out to.
I'm not sure who it is now.
Yeah, I can't remember which round of elections that was.
Feels like it's forever Grant Shapps, but that was ages ago. Yes, so yeah, former Home Secretary. So she slammed Capita for operating an extremely outdated and inefficient model, causing unacceptable errors and delays to GP pensions. So, so she's written a letter to government, which Pulse has seen, and it looks like it's written on behalf of GPs in her constituency who have obviously lobbied her. It would seem. Because she says GPs in her constituency have been experiencing an erroneous service with PCSE, resulting in numerous accounting errors, unacceptable delays, and stonewalling from the complaints team at Capita. So she's not happy on behalf of GPs in her constituency. So so interesting. And maybe after another 3 years, we'll get another provider, and or maybe Capita can turn it around during
We
the
shall see.
contract. We will
see. Talking of finances, our next story was then talking around ICB planned changes, wasn't it, Andy, in terms of what's coming through from particular ICBs. And some people may remember the news story we did about a year ago that talked about the Northwest London ICB bringing in an access-based enhanced service. And effectively, this is the new version of that, I believe. It's an ICB imposition, potentially, in terms of targets for general practice to achieve in order to have additional funding through enhanced services. Want to talk us through it, Andy?
Yeah, so I think the story last year was about urgent care centres or urgent care streams. And they were planning to make an imposition of this model upon the primary care networks in their area. By tying in participation in that with the other basket of enhanced services in the area. So basically, you have to do it all to get all the enhanced service money, or you opt out of everything. So twisting the arm, potentially in terms of tactics, and that was met by quite a coordinated response from, I think, LMCs, patient groups, practices, and some primary care networks, and they dropped that plan. But the same ICB, which is Northwest London, is back with another plan. I guess the attention grabbing thing here is that part of this new enhanced service is that they need to answer the telephones within 10 minutes. So it's a call center like performance targets for GP practices. I think that's the first time we've seen anything like this within any contracts, which is really, really interesting. The package of enhanced services is worth £6.6 million across the ICB, and in order to access that, primary care networks and practices need to accept everything within the package. They can't pick and choose. There aren't a number of smaller enhanced services. So the things that they're asking to do, I think it breaks it out somewhere. Here we go. So the requirements are around turnaround times and continuity. So they should code all clinical contacts, including GP appointments, in the ledger to demonstrate change in line with plan. Respond to 90% of calls within 10 minutes. Respond to online consultations within 1 working day, which I think is a standard contractual requirement. But I guess they're again
will be from October. Yeah,
they're linking that to this enhanced service payment. Ensure the top 2% of high-risk patients are flagged for continuity of care, which I think is quite interesting, actually. So they're including a measure to improve continuity within that, and increase NHS app registration by 10%, or an agreed local target or uptake is already above 75%. And then they have a table that sort of breaks out what the metric is and actually what the audit measure is that they'll use to judge that against. So if we're looking at call time, they'll say the audit, so the metric is call response time 90% within 10 minutes. So 90% target within 10 minutes. Online consultation within 1 working day. And they'll use of appointment time, including secondary care interface contacts. So I'm not quite sure how they will be using that to demonstrate achievement on those metrics. I'd have thought the only way really you can demonstrate that is to look at the cloud telephony data.
So the call data one will be cloud-based telephony. The online consultation one, I'm assuming, will be through the online consultation providers in terms of how long they've been left over. It's interesting whether or not they provide that data or not across the board for all online consultation providers. And then in terms of the continuity one, I find interesting because it mentions 2% of high-risk patients. So the key question here is what is classified as a high-risk patient? Is that a patient with multiple comorbidities? Is that based on age, frailty? Is that based on clinical aspects? That's the part that we don't have from this particular detail. And is that high risk as in high risk of admissions? Is that high risk of health needs? Is that, what does that exactly mean?
We don't have it here in the table. I mean, we haven't had chance to look at the enhanced service specification, but I believe that will be out there for people to have a look at. It will need to be published at some point if it hasn't been done already. There's probably maybe leaked out there as well, so there may be an answer to that. But yeah, that sprung to my mind as well, Gany. I thought, how are they identifying these 2% of high risk patients? But I guess they're going to do an audit of 10% sample of them to determine whether continuity was delivered. And I guess within the service specification, I think they need to define what continuity is as well. It's probably an element of seeing the same clinician at successive appointments, and they've said including follow-up after admission here as well. And then the patient empowerment and engagement measure is this sign up with the NHS app. And the plan is a patient experience survey to run in year, and a well-attended patient engagement event is held. So there's some additional requirements that are not sort of in those headlines that Pulse had brought out as well. So it's interesting. I mean, have you got any thoughts about, I guess, the content of this and also the tactic of bundling multiple things together in one combined enhanced service? What do you think?
Well, it's interesting. The content in terms of the mechanism of using this kind of level data was always commented that it would not be used for providing this level service or impact. But obviously we postulated that would probably be the direction of travel at some point by either NHS England or other organisations. Now, obviously, this has now been delegated to ICBs to decide. And I suspect North West London, whilst it being the first one to publicly go live with this, won't be the last to do something similar to this in that sense. The question of using that data and the morality of it, and more importantly, bundling it with the additional enhanced services, that is the one that I think many people are going to struggle with. The fact that it is being used not to provide additional resources to general practice, but it's actually limiting existing resources that you have to do this, or you don't even get the option of having them. That one I don't like, I have to admit, because that clearly puts the set that they expect some people not to be able to achieve this.
Yeah, but because of course there's the other enhanced services often cover things like monitoring of high risk medications, delivery of things like injections to treat prostate cancer, so things like that are often delivered as enhanced services. And again, whilst we've not looked directly at the detail of this, it looks like they're bundling multiple enhanced services together, I guess, in effect, to increase the leverage that they have on practices to get them to deliver these sorts of changes. They won't be able to deliver those enhanced services which practices may feel have a very clear and direct positive impact on patients. They won't necessarily be able to deliver those sorts of things unless they sign up to these additional things, which certainly have more of a feel of direct performance management of primary care rather than relating to payment for delivery of specific services, which has really been the purview of enhanced services in the past. So it's a bit of a change of tactic here. And I think many will find controversial.
I think one of the things to recognize is that, particularly some of those ones where, for example, 90% of calls answered within 10 minutes. If you are a practice that's already struggling because, for example, you're not able to retain your admin staff because of the potential impact, abuse, and various other aspects that they receive in terms of doing their job, this is not going to help this is another stick that's potentially going to be there to hit the practice with, and actually therefore leads to them having less funding, less effective, and possibly starting the downward spiral even more so for some of those practices in need of challenge. And as far as we've not seen, and it may be out there in the spec, in terms of support or aspects to help those patient practices where they are struggling for those reasons, it's not outlined at all.
Yeah. So, but and hopefully in some of those assumptions we've not got things too wrong. Apologies if we have, and please do correct us. Interested to know what people out there watching think about this way of operating around enhanced services from Northwest London, and whether they think this is positive or negative. Be really interesting to know what people think out there. I guess the next story is, I guess we just got a few that we were potentially going to cover if we had time, Gandhi. We've got the GPs could be liable for third-party errors and the protectionist policies of juniors. So, yeah.
So I guess to cover the data liability one, so this is a story that's come through. And so some of you may remember back last August, there was this whole thing about the GP update record, GP Connect update record function, where weirdly over one weekend almost the entire general practice did a unified action by switching off this access to third-party data in their medical records because of the concerns of some of the aspects coming through as part of the contract changes. Now, interesting to recognise that as part of the new GP contract, this is mandated that practice will have to switch this back on by October. And this allows, for example, pharmacies in Pharmacy First to write into your GP records in terms of the updated aspects of them providing that care, as well as private providers having access to read-only information of your records when they're delivering direct patient care. The key thing about this is that the BMA have come out and said that the liability of the integrity of that data is likely to sit with the GP practice. So if, for example, a patient is seen in Pharmacy First and incorrect data is inputted, that there is still the liability of the GP practice to make sure that data is correct. And there's a question of how much extra work, aspects of data continuity, as well as governance that comes into play in some of this will sit, because we still don't have the details to what this looks like in preparation for that switch on for practices. The suggestion is this is going to be a bit of a short-term spike rather than a long-term workload impact. But I guess it's still a question that still needs a bit more detail and answers in terms of practices, in terms of their role as data controllers. Andy?
Yeah, well, sounds like one to watch. I'm just thinking about the kind of specific examples that might happen just to make this come alive for people. So I guess we're talking about, well, all sorts of data that ends up there through GP Connect. But what we often get is notifications that patients have been seen in Pharmacy First for one of the Pharmacy First conditions. So let's say they've been seen for tonsillitis, for example, and we get some information come through from the GP pharmacy, which we often have to take at face value, and we click a button to add that to the GP record. At the moment, that's how it works. I think it might be more automatic actually in the future, with more kind of direct access being given. And once that's information is in the patient record, even if it's incorrect, we take responsibility for it. I mean, I guess that's my understanding, Andy. So, and then if there's an issue with that data, that that care event didn't happen, or that any of the data surrounding that's been entered by the pharmacy is incorrect and it's contested by the patient, I guess we're the people who have to resolve those issues. If there's third-party information in there about a third party, so someone who isn't the patient but is somehow mentioned or alluded to in the consultation, and that's later disclosed when somebody looks at the record, we're responsible for that too. So those are the sorts of responsibilities that we're talking about, I guess, Gandhi. Am I right? Pretty
much correct. And it's that question of then what is the mechanism for going back to those organizations potentially and saying actually this data is correct, incorrect, etc. at that point, where there's the liability raised in terms of a patient sees information that they shouldn't have seen because it's incorrect data inputted, etc. All of these are things and test cases nobody wants to know, because nobody wants to be the test case, but the same part need to know, because this is data governance at its deepest level that has an impact, and there's that responsibility that comes into play. And raises the question, if we are mandated to share this data, are we still the data controllers? Because we are being told we have to share this data whether we choose to or not, which actually by definition means you are no longer the data controller, if you think of it in some way.
Yeah, so I guess the BMA will continue to fight our corner on this, and we will have to watch this space, I think, in terms of where this lands. But it's worth being aware of, so this doesn't come as a surprise if there are issues in the future. And I guess the final story which we were thinking about looking at was GPs criticise juniors for protectionist policy against international graduates. So did you want to talk about this one, Gandhi?
Yeah, so this is off the back of the LMC conference and various other recent conferences that are due to happen in the near future, I believe, including the ARM conference. So this is on the basis of a recent...
And ARM is...
oh, gosh.
Have I put you on the spot?
Yeah, you have. Something resident medical, something like that.
Okay.
It's basically the BMA's resident doctors conference where they agree policies and principles.
Associate and resident medics.
Something like that. Yes, apologies, I can't remember, although it's a bit late at this point. But effectively, this is talking about the policy whereby it has been voted into contractual aspects in terms of prioritizing UK graduates for medical placements in training for both general practice and resident training as well. And I think this came up for a debate at the LMC conference a couple of weeks ago, and there's been some concerns and criticisms that this is a protectionist policy. I think there's two sides to this. We know that right now there are significant challenges in various different training aspects in terms of availability of jobs, training numbers, etc., and that kind of thing. And a question of should those be prioritized for UK trained graduates? What is the definition in that context then of this policy of a UK trained graduate? Because is that UK born and trained in another university and come back to the UK? Is that not IMGs in the truest sense of people who have trained completely and lived abroad and then come to the UK, which, let's not forget, the NHS would not exist without those clinicians who have come from abroad to support healthcare, particularly general practice. Many doctors that came across in the 50s and 60s from other countries, which is the reason why we have a functioning primary care health system in the first place. But I think, this is part of a very deep debate, I think, that exists in terms of the current challenges that we face in general practice, but also the impact that's having in terms of those challenges and the availability of employment and work and stuff. Because let's be honest, we have many GPs currently out there unable to find work. We have many trainees coming out of training unable to find work. And this is a key issue in terms of, I think it's going to be a hotly contested discussion topic moving forward.
It's interesting, I guess, just looking at the opening statements of the story. So it looks like it's the BMA Resident Doctors Committee in March, I think, voted in favour of a motion demanding that the UK government implement a specialty training recruitment process that lawfully prioritises medical graduates from UK medical schools. And then in Glasgow last week, the LMC representatives from around the UK voted in favour of a motion asking GP committees, so LMCs, to distance themselves from the protectionist policy passed by the BMA Resident Doctors Committee. So it's the LMCs wanting to distance themselves from that Resident Doctors Committee motion. It's interesting. I mean, yes, you can see the arguments on both sides, I guess. But I guess are you either welcoming to people from around the world who've always been really important to making the NHS function and continue to be important to making the NHS function, or are we prioritizing UK medical school graduates? And then there's the meritocratic element to this. Are we prioritizing the best people for the roles and jobs, which some people would argue is the right thing to do and not make any distinction between them. Feels like above my pay grade to resolve this, I think. I've not had a review with those committees.
But I think it also speaks to a system and a decision that potentially comes from deeper rooted challenges within healthcare currently in terms of the availability of jobs themselves, the skill mix aspect that we've talked about on numerous occasions on the channel in terms of, the availability of other clinicians taking up resources, funds, jobs, etc., and all that kind of stuff, and how that's utilized by different organizations and the impact that's having. And I guess also the aspect of the deeper society issues, which me and you are not going to talk about right now. So,
oh gosh,
no,
it's too late for those sorts of
absolutely.
those sorts of discussions. Good, okay, but so hopefully that's updated people to some of the stories that have been floating around in GP land over the last few weeks,
Mhm.
and I particularly enjoyed the story around the DDRP 217 odd page report, and the fact that GP partners have been given a quantified pay rise for the first time in many years. Whether
Supposedly.
that's sufficient or not is debatable. And we'll watch the space as to whether the money comes through to make good those recommendations from the DDRB. Any last thoughts, Gandhi?
Yeah, so I guess just in total, we covered, as you mentioned, the DDRB recommendation for 4% uplift in total to general practice, doctors, and various other aspects in terms of dentists across the board. We then also talked about the fact that Capita is back for another 3 years and their continuation of their contract as it transfers over to whatever the new mechanism or organisation will be, which is likely to be Department of Health in that time. But in addition to that, Suella Braverman, former Home Secretary, commenting that Capita is not the greatest organisation in the world on the back of potentially some politicking from her local GPs. We then also talked about data liabilities in general practice and the aspects of the GP update record switch on and the impact that may have for general practices as data controllers. We also then talked about GPs criticising resident doctors of potentially protectionist policies being brought into place in general practice, as well as a couple of news stories around Medicus and various other healthcare aspects.
And ICBs in Northwest London
Yes.
using imposing call center like targets on GPs using an enhanced service mechanism, 90% of calls to be answered within 10 minutes amongst some other measures. So lots going on.
Absolutely. So if you want to see more of those details, go back and watch those relevant sections. We'll put the timestamps down below so you can do that. Absolutely share this with your colleagues in practice so they can be aware of all the different stuff coming up in general practice. If you want to find out more about what the UKHSA are thinking in terms of infection impacts and resource use across healthcare in the NHS, then definitely check out this episode when it comes up, which will be next week, as me and Andy go through that document in more detail. And as always, we'll be here to take an answer your primary care and learning. We'll catch you guys in the next episode.